Good evening, everyone. Myself, Dr. Suman Narayan Swami. With me, Dr. Guru Prasad Osurkar is a director and lead consultant in neurology and head of Parkinson's disease and movement disorder program, KIMS Madhepura. Today, we'll be talking about the topic overcoming vertigo, practical ways of regaining balance and confidence. So, this session will be more of interactive sessions where we both share our knowledge on how to go about vertigo evaluation and then what are the remedies for that. Uh, the common questions asked by any common person who is walking through our clinic would be this. Next. What is vertigo? What are the causes for vertigo? What are the associated symptoms with vertigo? How do healthcare providers diagnose vertigo? How do healthcare providers treat vertigo? What are the risks and complications involved in vertigo? How to prevent vertigo? And what is my prognosis? How well I can, or how fast I can become better or get rid of this vertigo symptoms. Next. If I just want to explain what is vertigo, I think you will have to watch this video. Next. Just look at the eyes, how your eyes are wobbling around. Okay, if you can just see the video next to each of the eye where the TV is there, side, right side and the left side videos. Yeah, see that? This is what your image looks like when you get in vertigo. Same thing on the right side. You can just see that. This is what a patient actually feels when they say, I'm getting vertigo, and the eyes is what tells us all about. Okay. So, whenever the body is still, when the person is not moving, the entire surroundings revolve around him, or the feeling of revolving around him is what vertigo is. There are multiple causes for vertigo. I think last lecture we actually spoke about what the causes of vertigo and all those things. Now, let us talk to Dr. Guru Prasad regarding how a neurologist's perspective of approach would be for a vertigo patient as soon as the patient walks into his clinic. Sir?
Are you able to hear me?
Yes, sir. Very clear.
Yeah. Thanks, Dr. Suman, for having me for this interaction. Very well represented in your initial remarks and the presentation. Very few times patients come directly, telling that I have vertigo. They just mention about giddiness. As a neurologist, giddiness, lightheadedness. Everything seemed to be almost the same, thing from the patient perspective. Uh, as a neurologist or as a physician, so it's our job to tease out what exactly they mean. So, when you say vertigo, is basically, as you mentioned, it's a spinning sensation. But sometimes patients may not be very clear when they come out with the history. So, we need to, go into details about their symptoms, uh, associated symptoms, like is there any what exactly what they mean, whether it is just feeling of lightheadedness or is it spinning, exactly spinning sensation. If they come out with a feeling of spinning sensation, then it becomes easy that it's otherwise proven. But if they have very vague symptom, we'll have to go into more details, whether it is associated with the change of position of the head. Is it associated with the sensation of nausea? How long the duration symptoms are? And it occur across the age group. So depending on the age group affected, what do the symptoms mean in that particular situation. So we go into the details of the symptomatology. And also for us as a neurologist, if someone at 50s, 60s or 70s come out with giddiness, our thing would be to look at the red flags, uh, because peripheral vertigo, as we understand, coming from the inner ear vestibular system, is a little benign. We don't want to miss out on central causes for vertigo. So we ask for other symptoms of brain stroke. Like, for example, is there any blurring of vision associated with that? Is there any paresthesia? I mean, that means sensory symptoms in the limbs, any weakness, unsteadiness, uh, and is it persisting more than few hours, and also any other change in speech? All that symptoms suggest that it is not just routine vertigo. So for us, one thing is to classify, and another thing also is to make sure that we don't miss out any other causes for vertigo, because we know there is a strong possibility of central cause for vertigo in certain age groups. So we'll have to be very careful in thing, and then we start examining them. And then again, the approach will be the same. We look at various signs for vertigo, which we can pick up, like the type of nystagmus, like you showed in the video, the eye movements, and then we then examine other neurological parts, like we look at what we call head impulse test. We do a simple bedside head impulse test, which has a very high index of precision in terms of differentiating between central and peripheral vertigo. And then we examine for other neurological deficits. Is there any ataxia while walking? Is there any clumsiness in the upper limb, sensory loss? All that things we examine, and then we come to a conclusion whether this is peripheral and central. Then accordingly we investigate further.
Yeah. Thank you so much, sir.
Yeah.
If I need to summarize this, rightly said, vertigo is not always a peripheral thing. It can be involved with central cause as well. Central meaning related to something related to brain and nervous system, and peripheral meaning something related to ear related thing. I think sir elaborately told what are the investigations, how sir approaches, because we do see vertigo patients coming directly to our emergencies also than an OPD basis. How do you differentiate? And rightly said, first thing is about the age and what are the other red flag symptoms what we look for. That's right point what sir told. Sir, more than uh, as an OPD, when we sit and and you see the patient walking in with the complaint of vertigo, we do know we do a subjective assessment, like rightly mentioned, head impulse test, and we probe more into the history, more into a little bit of physical examinations and all those things. How do you uh, rate the objective evaluations of vertigo? For example, if you like blood test or imaging studies or hearing test or vestibular other tests like video nystagmography or other tests.
Yeah. So the clinical, history taking and examinations are very, very important to start with. However, sometimes it's very difficult just to depend on the history taking and examination to clearly define. So ultimately, you need to, depend on investigations. So when, for example, when a patient has symptoms suggestive of lightheadedness, it's not exactly the vertigo. Like if there is a elderly patient coming with orthostatic giddiness, what sometimes they may come out with spinning sensation in the early morning when they get up from sleep, or in the washroom they may feel dizziness, or sometimes they may have falls and come. So then it becomes very important to do basic investigations to rule out anemia. Sometimes you have a low hemoglobin, that itself can cause dizziness and falls. So, and someone who's got Parkinsonism in the background, they may can have blood pressure fluctuations, and that can itself can cause things. So all this has have to be kept in mind when we evaluate these patients, and then accordingly investigations have to be done. So once that is done, once that is ruled out, do routine investigations and all. And if, for example, as I mentioned, if there is a little strong suspicion of central vertigo, for example, your no, hit test is negative. If it is positive, that means that if there's a corrective saccades, then it is more likely to be peripheral. But if it is a normal hit is negative, so there's no corrective saccades, then it goes more in terms of central vertigo. And if there are other neurological features suggestive of central vertigo, then you go for imaging, rule out any kind posterior circulation stroke. Then if there is any vascular occlusion, if there is any thrombus sitting in a vessel, if they're in the window period, then you go on to thrombolize them and all. So that goes different. And once you do that, and if the hit is positive, that there's a corrective saccades, then you go on to various positional maneuvers like Dick Salpix or rollover test and all. So the yield is very good. And yeah, sometimes if it is very straightforward, and I think you may pick up on the bedside itself. But if you don't pick up the bedside, that means that it is not it is not positional vertigo or BPPV. It has to be taken to the next level of using tools like VNG, because the yield is very good. You may have a subtle nystagmus. You will not be able to classify on a routine examination what's the type of BPV it is. So for both for identification, that is recognition, and also classification of the type of BPPV, you need thing. And sometimes even the VNG may not be enough. So we may require help of VHIT. Sometimes require help of WEMP or CWEMP or VWEMP. For further thing, if we are looking at more of other types of peripheral vertigo. So if you go on a very systematic analysis investigations, so then you can have a solution in terms of that you have a hypothesis, and you can find a clear cut reason for that type of symptoms the patients come with. So systematic analysis will definitely help to guide us in terms of diagnosis. And also, as you all understand that VNG and I think we also will help us to do the repositioning maneuvers. So that becomes a very useful tool in terms of both the diagnosis and therapeutics.
Yeah. Thank you so much. So, investigation based on an associated symptoms with vertigo, say postural changes, what the patient feels, whether he has hearing loss or not, if there has any other neurological signs like paresis or headaches, those kind of things, we go about more of investigations. So, most common question by patient is, sir, I went to three, four doctors. I've got all my evaluations test, like any blood test you tell, we have got it done. MRI is done, CT is done, everything. All the doctors' reports are all fine, sir, but still I feel spinning when I lie down. This is a most frequent complaint or uh, 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 we hear from the patient. So, how do you take this or explain this to a patient, sir?
Basically, that's what because it's a chronic problem, it's a recurring problem. So even if you would have treated them very effectively with the medications, because that is not the complete solution. Investigations, blood investigations, and medical treatment has its own limitations. So that doesn't solve the problem. So that's not the complete solution. So I think that's where all these tools and systematic analysis, and investigations, detailed investigations help us to come to a conclusion. Because just making a diagnosis of vertigo is not good enough. We need to classify what is the reason for the vertigo, peripheral, central, if it is peripheral, whether it is BPPV or any other, whether it is vestibular migraine, whether it is any other peripheral reason for vertigo, whether it is paroxysma, vestibular paroxysmia. All these things has to be properly categorized. Then only you can, clearly treat them. So, but you can have a small percentage of patients whom we can't classify even despite the best of the investigations available right now. That can be a challenge. But having said that, I think in our experience with the recent availability of all this posterography and craniocorpography, CVM, VVM, we can certainly come to a conclusion, and then treat them thing. And then vestibular rehabilitation also plays a very, very important role. And because one thing is, you can fix most of the times the BPPV and other vestibular thing, but some of the chronic, and recurrent uh, vertigos require long-term rehabilitation. So that's where important to follow them up closely, and then modify our rehabilitation measures to give them much more long-lasting relief. But at this
Yeah.
stage, I want to ask you, Dr. Suman.
Yes, sir.
So in your experience, so what is the percentage of patients who require, regular follow-ups, reassessments, and repeat testing, and then rehabilitation? What is the percentage of patients? Because you've been practicing vestibular thing for a long time.
Sir, if I need to classify like central versus peripheral, okay, central causes we do get and then we do manage with medical support. So if pertaining to only the peripheral causes, I would actually put this peripheral causes into two major chunks, sir. One is a mechanical dysfunction like BPPV. BPPV is nothing but a positional vertigo where the crystals from the inner ear dislodges and joins in some of the semicircular canal. And the other one is something chronic or any other issues other than mechanical dysfunction like inflammation or any kind of infections or any kind of bone erosions and all those things. Yes, BPPV patients require a close monitoring of at least 2 3 follow-ups. I would want them to come back because the repositioning maneuver what we do, we try to teach them, but sometimes they may go wrong when they're doing at home, which may create unnecessary problems. So I would closely monitor them for a week. So, but rehab, the other set of patients whom I was talking, maybe dysfunction because of infections or any kind of chronic conditions. Vestibular rehab, we do train them like 4 days a week, up to a month or 1.5 months, with a tailor-made rehab program for each patient. Different rehab programs is one set of patients. Minimum of 1.5 months, 2 months is what we target with the intense balance training for them. The other set of patients, we do ask them to change their lifestyle, little bit of diet modifications when they come with a complaint of migraines or say Meniere's disease. So a little bit of lifestyle modifications and uh, 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 diet modifications would definitely help them, sir. Uh, Vertigo, yes, definitely we need follow-ups from the patient because we need to track their prognosis. Thanks to the technology, because now we have a lot of good technology where we can actually see the improvement with the results than subjective. We do have an objective measures to tell that okay, this patient has improved from say 20% to 50%, from 50% to 90%. We do have that thing, but yes, follow up is one thing. And I do categorize this peripheral dysfunction into 2 3 categories, and then based on which category they fall, the treatment plans changes.
So we know that, see, when we label, uh, so uh, so benign, labeling of benign paroxysmal positional vertigo, we know it's not benign. So even though name
Benign.
suggests, and that has now undergone changes now. So it's not anymore benign
Yes.
because the symptoms are very unpleasant. The patient
Yes.
suffers quite a bit. They have a lot of nausea, vomiting, and then they have a
Yes.
lot of imbalance and all. So when it comes to peripheral vertigo, especially BPPV, so which are the ones which are very severe and very difficult to treat? Which are the types of BPPV which has difficulty to treat and all?
Yes, sir. So traditionally, BPPV earlier, because when we didn't have this technology or much knowledge about it, we used to think, okay, it's only about the posterior canals of right and left. And now, if we want to classify, we have more than 9 types of BPPV involving posterior canal, lateral canals, anterior canal, short arm. There's a lot of things. And there are few conditions where we call it as atypical BPPV, which is not a traditional thing, where the particles are stuck somewhere else, or the particles are jammed between the canals where it is not coming out of for multiple sessions also. Those are difficult ones, but very well treatable ones. Uh, these patients becomes more challenging to do without instruments. That's when instruments play a major role in assessment of the eye movement, because different positions we may have to repeatedly do maneuvers for recorrecting those things. Yes, now it's been long thing that it is not only the posterior canal BPPV is what we generally see. We do have 9 types, and there are atypical ones also, which is manageable but little difficult, sir.
Right. So at this juncture, I want to mention that the medication what we use in vertigo, especially in BPPV, sometimes you've seen people are on high doses of betastine.
Yes, sir.
So that is only for symptomatic relief. That doesn't solve the problem. It's like giving paracetamol
Yes,
for
sir.
fever. So it is only going to help to just give some relief of symptoms, which is needed, which is also very
Yes.
important part of the treatment. But
Yes,
that is
sir.
not a solution. Solution is repositioning maneuvers according to the type of BPPV someone gets on the investigations on the VNG, or just on the bedside maneuvers.
Yes, sir.
So that is very important to understand. So when someone patients, most of them come and say, I've been taking medication for so long, so it doesn't work, it doesn't help, and by the time I stop it again, there is a recurrence. So important is to understand that that is not the solution. The solution is to get the right treatment, and complete solution comes with the repositioning maneuvers. But
Yes.
sometimes it requires a follow-up. Repositioning maneuvers may not be once follow-up. One repositioning maneuver may not help. You need to do it at home, and then sometimes you'll have to do it again and again.
Yes,
So
sir.
having said that, I wanted to ask one question is how to, a lot of patients have, once they have undergone repositioning, and how to prevent that happening again and again. So,
So,
Dr. Suman,
yes, sir. That is the most frequently asked question also by our parents. How do I prevent of reoccurrence of positional vertigo? Our only solution is get your blood routines checked, D3 and B12s in a good thing, and not having prolonged bed rest, and not a sudden jerky movements. Those are few tips what they can follow, sir. That would be sufficing.
right. So, and on this context, I also want to mention that a lot of patients do have vertigo-related like symptoms along with migraine.
Yes,
So,
sir.
when we diagnose someone with vestibular migraine, the added preventive measures are that you need to have a regular lifestyle. That means you need to at
Yes,
least
sir.
sleep for 7 hours, especially in younger age group patients, children need to sleep at least to 7 to 8 hours. You need to have a regular meal. You can't miss out on your meal. All that becomes important for prevention of things. So if you prevent headache, you prevent vertigo. Simple. If it is vestibular
Yeah,
migraine,
yeah.
so
Maybe have
same
some physical
measures like
exercises also regularly.
correct, correct,
Yeah.
and good adequate hydration. Uh,
Yes.
and the specific triggers for migraine headaches, like for example, if someone gets headaches frequently when they are exposed to sunlight, so cover yourself, cover your eyes, cover your head, the cap or wear goggles.
Yeah.
And ladies, we have seen people having head bath and having headaches, and they also can develop dizziness, vertigo. So, drying the hair quickly after the head bath. So all these simple measures, or sometimes some of the food items like spicy food, chocolates, can also ground nets. We have seen that triggering thing. So avoid any kind of trigger which can cause headaches, and that itself can thing. And if it is very frequent and all, then we use migraine prophylaxis and SOS medications to arrest the particular headache, and that in turn also treats vestibular migraine. So
Sir,
that's
there
what I
is,
wanted to add on.
yes, sir.
Yeah.
So there's one question. Can vertigo be cured, or will I need to manage for long term or a lifetime? Will I come back to my normal routine from this vertigo? This is the uh, question which is
Yeah.
asked by most of the
So
vertigo patients.
yeah. So most of the times, yes, there is a cure for vertigo because we know that benign paroxysmal position vertigo, which is the commonest type of vertigo, can be treated effectively. Like effectively in the sense that there can be complete cure. But for that, we need to systematically, approach the where the vertigo is coming from, where the BPPV is coming from, and then accordingly treat that. So it means that majority of the patients with peripheral vertigo can have a thing. But some of the patients who have vertigo because of Meniere's disease, or if it is ototoxicity. One more thing, some of the commonly used drugs, like for example, someone has been on like streptomycin, aminoglycosides, or medication like hydroxychloroquine. Some of the drugs can cause
So to summarize, what was Sir speaking about? Yes, vertigo can be cured. You can get back to normalcy in the life. Only thing what is required is a right diagnosis, right treatment, and a team approach where you involve neurology, ENT, and a right team and audiology team to cure your vertigo, and say no to self medications. That is most important thing. Uh, One more thing I wanted to highlight here before ending this talk is vertigo is a symptom. It can be caused by several reasons, from the inner ear till the brain and the cardiac system. So, right investigations will lead out to a good information about where the problem is coming from. Once we know where the problem is coming from, to treat that becomes very, very easy. Yes, there are conditions which cannot be cured fully, but can be managed efficiently. So only thing is we need a right diagnosis from the most of the investigations, because vertigo is not issue. It is not seen in MRI or a blood report. It needs a special investigations also. So based on that, definitely we will be able to manage the vertigo. I just see a few questions. Follow up. How often should we follow up with monitor and monitor the vertigo? Uh, as the doctor prescribed, yes, for different conditions, there's a different follow up time depending on what conditions it is. So, neurological conditions, definitely close monitoring is required. For peripheral conditions, until the symptoms subsides, it will have a rigorous follow up. After that, very rarely. How can I prevent vertigo? I think we answered this question. Having a good lifestyle, hydrations, uh, avoiding the trigger symptoms, that would help you to prevent vertigo.
uh, and some of the diseases requires little salt restriction, like disease requires restriction. Sometimes
Yeah.
diet also plays a role, but good hydration always helps both peripheral vertigo and other conditions like orthostatic hypotension. A lot
Yes.
of things can be treated with adequate hydration.
Yes. Sir, I think we have had a good interaction, sir, and hopefully we have delivered good information. So I thank you for joining this talk and giving us a lot of information from the neurology's perspective.
Thank you, Dr. Suman, for having a lively interaction and touching upon a very common, symptom of vertigo and various manifestations, various reasons for thing, and how to treat, and how to involve investigations like VNG thing. So we'll probably have more such sessions on this important topic. Thing. Thank you for involving
Sure.
me for this.
Thank you so much, sir.
Thank you all. Thank you all. Thank
Thank
you.
you. Thank you.